Good afternoon. More of me. Thank you for the fantastic lunch session run by Joe, but the rest of the speakers were really phenomenal. So we're going to wind up the day with a quite large panel, but I really felt it was really important to have all the different aspects at which we can approach this issue present. I'm sure there are more, but I think there are no more seats on the stage. So thank you all for being here. It has been an inspiring day. This morning you heard Dr. Christine Moutier provide her insights into the scope and etiology of the issue of mental health and suicidal ideation, and also how suicide impacts healthcare workers in particular and how to safely approach them. In this session, I brought together an all-star panel of experts who are committed to improving the well-being and mental health of healthcare professionals. As the contributors to mental health disease are multifactorial, biological, psychological, sociocultural, so are the potential solutions. Each panelist has a unique perspective in advocating for change. In this session, I hope to highlight some of the work that is ongoing and to stress the importance of working on self-care coping in parallel to cultural change, in parallel to infrastructure and cultural change. I hope that this will inspire all of you, as it has me, to get involved. First of all, I'd like to give a brief introduction because there's so many of them. I'm sorry, I'm going to keep them brief. You can PubMed all of the people up here. And they are extensively academically successful. Sorry, been getting a lot of, I just want to, Jill, did you email me or text me?
You can just, that's fine.
I got it, okay. So Jill Barclay-Roy serves as the National Affiliate Director for Emerge, an organization that recruits and trains Democratic women to run for office and win. We like that. After completing her undergraduate work at U of M, you've heard my alma mater, Jill relocated to Maine in 2004, where she quickly became involved in local and statewide politics. With a focus on issues with the LGBTQ community, Jill is a public speaker and trainer on the issues of equity and justice, various policy topics that impact women and children. And also, she happens to be the sister of my close friend, Tina, that you've heard about this morning. Thank you for being here, Jill. Jessie Gold, who you heard about through the lunch session, is a psychiatrist at WashU in St. Louis, who has been interested in the healthcare worker mental health and the culture of medicine since she got her master's thesis in anthropology and did her research for it in pre-med as a culture. Advocacy and change regarding healthcare worker mental health is central to everything she does. From the healthcare worker patients and families she sees in her outpatient clinic personally, to her administrative leadership working with well-being in her hospital system, to her research, and last but not least, for her popular press and social media at Dr. Jessie Gold related advocacy. She's a burnout expert and a constant work in progress. I asked them to give me sort of informal bios, so Colin's is going to take it to a new level. Dr. Colin West is a general internist and biostatistician at Mayo in Minnesota, who has been called the OG in physical well-being research and advocacy work dating back to nearly 20 years. One of his greatest accomplishments is earning honors in surgery, even after disclosing he was bound for internal medicine. He has never been a professional tennis player, but he did once lose less badly than French Open champion Michael Chang to the same player. Dr. Michael Maddus is a former juvenile delinquent. That's not a joke. He was arrested 24 times, 5 reform school stints, and a high school dropout who went on to become a professor of thoracic surgery at the University of Minnesota, where he practiced for 20 years. 12 years ago, he was brought to his psychological knees. He was burned out, his career was no longer fulfilling, he and his wife had drifted apart, and he had lost a young woman on the table. Then, after major back and hip surgeries, he became addicted to prescription narcotics, which led to a 3-month stay at Hazelden, which is a rehab center in Wisconsin?
Central City, Minnesota.
Minnesota. How could I forget? After graduation from rehab, Michael attended meditation and self-compassion retreats and trained as a teacher of self-compassion, and he has authored academic papers on resilience and second victim syndrome, which we'll hear a lot about. In 2010, he was asked to chair the wellness task force for the STS, where he also hosts the Resilient Surgeon podcast, which I'm sure many of you have listened to, where he has an incredible lineup of guests who are leaders in the fields of resilience and mental health. Sunil Geevarghese is a busy clinical hepatobiliary and liver transplant surgeon, and it serves as the vice chair of education at Vanderbilt. Among other roles, he's a passionate advocate for surgical trainees on the topic of moral injury. His main research endeavors to understand the psychological impact, immediate and chronic, from caring for patients who experience surgical complications. He began the Vanderbilt Resilience Rapid Response Team, a special trained team of surgical residents and faculty that facilitates early recognition and support. A founding member of the ASTS Wellness Committee, he has helped them develop a peer support network under the guidance of Dr. Joe Shapiro, who is an associate professor of otolaryngology at Harvard. In 2008, she founded the Brigham and Women's Hospital for Professionalism and Peer Support, where she served as the director for over 10 years. She was one of the Brigham's first women division chiefs. She continues to educate and assist organizations in developing specific programmatic and educational approaches such as peer support, disclosure and apology, well-being programs, professionalism initiatives, and conflict management. Chris Bundy is the executive medical director of the Washington Physicians Health Program, which you heard me discussing earlier today. Immediate past president of the Federation of State Physician Health Programs and clinical associate professor of psychiatry at the University of Washington School of Medicine. He previously served as the mental health service chief and chief of psychiatry at the VA Puget Sound healthcare system. He draws from his experience as a healthcare leader, medical educator, a recovering physician, to support education and advocacy efforts related to physician health and well-being. As a physician in long-term recovery, he considers it a privilege to provide care and advocacy for healthcare professionals in need. Thank you for being here. So I think I want this to be hopefully relatively informal. I wish we could get questions from everyone in the audience, but it's just too large of an audience, and I really want to make sure we highlight some important things that I've learned along the way this year. I'm going to sort of ask you all to, I have each a question. We'll start off with one question per piece. And please feel free to respond if you hear something that, you all want to comment on. I want this to be informal and to make sure we highlight really important things. I'm going to start with Jesse. In addition to your research, you treat healthcare providers in your clinical practice. We heard a little bit about that in the lunch session. Can you discuss some common themes that you find and what would surprise us? Depersonalization, signs and symptoms, things like that. Could you comment?
Hello, sure. I always like going first. It spices it up. So, I see healthcare workers, but I also see their families, which I think is important because we don't talk enough about how this affects families. And there's not a lot of data on that either. But from the healthcare worker perspective, I will say people tend to come late and come sicker, meaning that there are probably a lot of things that they ignored along the way to get there, and by the time they come, they're a lot sicker and maybe at the point at which someone like me might prescribe medicine. Healthcare workers kind of fall in two camps, and one's like, I don't want to take meds, that's bad for me, or that's something that makes me worse or not a good doctor, or give me a med so I don't have to talk about my feelings, which is probably maybe the more common one, which is can't you just give me a pill that wipes all of this out? And I wish I could, but that's not a thing. And mental health is not good enough for that to even work. So that comes up a lot. I think, people tend to point out that they're disconnected from their work and not putting that extra bit into it that they always did. You can use words like depersonalization or cynicism with that. But I think really what it means is there's more to us in our jobs than just errors, right? Like errors cause more mental health problems, which we heard, but there's something that makes us who we are and who we are as a clinician that people come to us for that. And a lot of times that's the thing that goes first. Like people will say, I'm just not acting myself in clinic. People have pointed it out to me. My patients have said it. I've heard that from people. And I think that's a big thing. I get asked all the time about licensure and whether I'm documenting. I use Epic, so I do, but psychiatrists are beat over the head about what goes in a real chart and what shouldn't because people get so anxious about that. But I think I have lots of patients that very clearly ask me what I'm writing, why I'm writing it, or is anybody going to see it? How many more protections can I put in place to prevent people from seeing it? And all of that kind of thing comes up probably more with physicians than anybody, but I also see healthcare workers, not just physicians.
So a follow-up to that is, what do you have to show people? That's really what we all want to know, right? What do you have to divulge to someone? I assume if you're worried about them harming themselves or others.
Yeah, I mean, you know, it's sort of, I do a full intake just like anybody would for a mental health visit. So I also ask like physical illness and other things that could be mimics. And I also ask like medications and things like that. But I do a full like psychiatric review of symptoms. So that's gonna mean that I ask you about psychosis. It's gonna mean I ask you about mania. That's gonna mean I ask you about substances, which like, again, I get an extra pause and like, can I tell you and you don't put it in the chart kind of thing. That's complicated. You know, I think that there are things that don't need to be in the chart for whatever reason, but if like it's related to a diagnosis and what's going on, you can't like not put it in the chart. But, you know, I'm pretty mindful about that. I think everybody that is in mental health is. Therapists write really quick notes that usually just say, discussed family systems and trauma, right? I tend to not put like big details about trauma in someone's chart. Like I'll say, patient has significant stressors from the workplace, previous trauma, et cetera, very broad things, so that nobody would know that information. I've had patients say they were afraid they'd like go get their appendix, like they had their appendix burst, and then somebody will see my notes and it'll make them think differently about them, even if it's like their appendix. And so that does come up. Putting the diagnosis in a way that you can see it on the chart as a problem list does come up, but I try to be really mindful and as much as I can deal with patient preference.
And if we changed the stigma around it, it wouldn't be a big deal anyway.
Correct.
There we go. Next, Sunil, I hope you're all okay with me calling you by your first names.
I love that. Thank you.
Okay, good. For those of you who aren't familiar with your work and this idea, what does moral injury mean? We had a little bit on the lunch session, but some of the people here weren't in the lunch session. It sounds a lot like PTSD to me. Is it similar? Can it be avoided in any way as a surgeon or as a physician or healthcare provider in any way, shape, or anyone for that matter? And what are the barriers to people seeking help? I just asked you 4 questions.
Well, that's great, because
No.
I wrote them all down. No, I do want to take the fact that I have the microphone to first just take a moment and thank you, Carrie. You have defibrillated the rhythm of American surgery today with your presidential address, and we did not have the opportunity to thank you appropriately. So I really want to say that. So, to your question, there is definitely a lot in similarity between moral injury and PTSD. In fact, the term goes back to the Vietnam War, when Vietnam War vets were coming back and actually discovered to have things that were a little different than fearing for themselves, but a fear for moral breach that they had experienced by bearing witness to something. Similarly, when surgical residents, trainees, and attendings see surgical complications happen, and in essence, all of us at some level derive a huge amount of satisfaction when things go well. I think in aggregate, we can suffer tremendously when things go very poorly. So there's a lot of overlay there. And then there are subsequent stages when that's not met with support, where it can snowball and nearly decimate lives. professional as well as medical and personal and mental lives. So I think that's where that continuum happens. And ideally, by normalizing it, destigmatizing it, as what we're doing today and what you did a while ago, we'll see that that changes, that we'll be more comfortable talking about this.
Can it be avoided?
I don't think moral injury can, per se, be avoided. I will say that the same event can affect people in different ways, whether it be distress or actual injury. So that makes it complicated as we try and help support individuals, but I don't think it can truly be avoided at some point in your career. How we manage that, I think, is the key element, and whether that transitions to other more complicated situations like second victim syndrome, et cetera, which I know is not a perfect term, and Joe is going to correct me in just a moment, but I do think it's an important dynamic that we broadly talk about and think about.
So my questions are rhetorical a little bit, right? We can't avoid it, so we need to have tools to soothe it and to help each other get through it. So,
Right on.
Dr. Shapiro has been in the game a long time. We were very fortunate to have her, first of all, in Boston, but also at our retreat this summer, speaking to our executive council, and I appreciate you and Jesse and Michael, and I think that was it, of you that were there. Can you discuss, well, first of all, some of potentially the misinterpretation of the term second victim syndrome? And then why don't you start there so I don't throw a bunch of questions at you. Like you're up at the podium, you got to write it down. No, go ahead.
I also want to thank you and also thank the panel and all of you, because there's a lot of other things you could be doing right now, and you've chosen to be here. And I think that's huge. It just says how much you care and how much you're interested in change, I think, both on a personal level and systems level. And this work won't continue without all of us working together. So second victim was a term that was coined years ago, and I thought it was amazing because it was the first time we realized, oh my gosh, yes, we are affected by having inadvertently caused patient harm. But over the years, I've come to think of it needs to be retired. And the reason I feel that very strongly about that, and I wrote an opinion piece about it with a counterpoint from the people who think it should keep going, is that I work very closely with patient advocates, and they really don't like our referring to ourselves as victims when we've harmed them. It just really upsets them. So to me, it's like, that's enough. I don't need the term. Nobody's ever said, what are you talking about? So that's why. But I think it really was a very wonderful thing to shine a light on something.
Mm-hmm. The other thing I want to ask you about is, we hear a lot of buzz about psychological safety. That's been brought up a number of times. And I believe you're involved with the ACGME in terms of professionalism or bullying or something you want to discuss.
Yes.
But I'll kind of just describe what that means, psychological safety, and also whether or not this psychological first aid, we're also hearing about that training, if that's something that is, it's sort of a buzz term for everything, or what does that mean exactly?
Yeah, I'll try to separate the two. So, psychological safety is the sense that, well, first of all, it's predicated on mutual trust and respect. So if you think of it, psychological safety in a healthcare team, it's this sense that, and the not the term, but some of the research on it came from Amy Edmondson, who looked at it in medicine in terms of teams, is this confidence that you won't be humiliated, rejected, ostracized, or demeaned for not knowing or for speaking up. And it's so foundational to people's ability to function. But as you can imagine, saying it's predicated on mutual trust and respect is not a given. And so psychological safety has to be both built and sustained. And you can also imagine it's harder to build it than it is to tear it down. So that sort of segues into this question of what's the relationship between professionalism and psychological, which the opposite of that is unprofessionalism, which undermines psychological safety. What's the relationship between that and well-being? And I've been trying for years to really make that connection, because I think if we do not address psychological safety within our organizations, within our teams, we are really not going to have the full potential of making it feel like we love our work. Because if you think of, and this came up in so many people's stories today, is one of the things that keeps us going, and not just keeps us going, but energizes and replenishes us, is this sense of connection. And this feeling like we're all there for each other. And so I think we need to be paying attention to building psychological safety and preventing it from being destroyed by unprofessional behavior. The other question you asked is, what's peer support? So peer support, we started peer support because, many reasons. One is the research showed that we were involved in that after certain traumas that we experience as healthcare providers, but many studies were done in physicians, where we want to get support from would be for a physician colleague, not our incredibly talented and important mental health, behavioral health professionals. But in those moments, we want to be able to talk to someone who gets it, who's been there, who knows what it feels like to perforate someone's pharynx. Doesn't have to be the pharynx, but we know what we just know what that feels like. And so we started peer support. And the reason I think you need to be trained to be a peer supporter, although, it doesn't have to be necessarily as formal as I do it, is naturally, especially I'll say as surgeons, what we want to do is we want to fix things. And this is not a moment you can fix people's problems. So you have to be taught really how to sit with somebody's pain and then to help them to navigate that pain, which is very different from, I will take your pain away. You have a Zenker's, I will make it gone. It's just a whole different way of being. And I think, everybody would benefit by learning some of the skills around that, but it's to meet a need that I think is really very specific to our profession, which is we are dealing with very unique stressors. And that kind of perspective of somebody who knows what that feels like, I think it's magic.
Dr. Maddus. First of all, I want to thank you personally. Michael met me through a close friend, Amy Fiedler, right when I was in the midst of my second month of rehab when I was in Chicago. And he's been a close advocate and friend and confidant ever since. No longer confidant, I guess, since everyone knows. But him sharing his story and being open with me, particularly as a surgeon, as an academic surgeon, was really meaningful for me and supportive. So I applaud you for being open and honest. You're the OG of sharing your story. And he's spoken in a number of venues, including the American College of Surgeons this year, when I wasn't outed yet. So he was going to the ACS this year was really tough. It was the first meeting since last year, and that was a tough meeting to go to for me. And he was there also to support me, not for me, but he was supportive of me there. So since you already started sharing, I hope that you could talk a little bit, even more so, about how you felt after treatment and your potential return to work. I'm hoping, because I know your story, that things have come a long way since I'm going to be going back to work next week. I hope. Excuse me. I want to know your experiences and just to let people know how that felt. And
yeah, it's just one person's story. That's all I can tell you. But I think there are common threads in it. First of all, the word addict that Carrie alluded to is a highly pejorative term, and I bristled against that just like she did in the beginning. It puts you in a box. And I'll never forget, I learned after I got out of treatment that one of my colleagues had referred to me as just an addict, okay? And, the University of Minnesota, and whatever I'm saying about my job and everything, there's no criticism of my position or the University of Minnesota. Everybody was doing the best they could at the time with the skills that they had. I have great, fond memories of that place. It was an incredible career. Having said that, things could have been a little better in terms of how it went down for me. because I felt like the University of Minnesota and the surgical department was a big part of my family. And when my partner told the chair that I was impaired because he knew I was struggling, and I was called up and I was told to go and report to the Health Professional Services outfit and let them know how it goes. And so I walked out of the hospital that day. My life basically ended, it felt like. I was in the throes of prescription narcotic addiction that I had tried every day to stop. I'll just take one less pill today, and then 2 less the day after, and I failed over and over again. And for somebody that had succeeded in everything in their life, this was an incredibly it was demoralizing beyond comprehension. And that's one of the things about addiction. It is morally, it's demoralizing over time. And so even though my wife knew there were troubles, she of course being addicted to something, didn't know the extent of it. So basically I was in the car in the middle of February in the freezing cold trying to figure out what to do here. And you know, I pretended to go to work for 10 days and not sleeping. And this is the first time I've revealed any of this in any circumstance. And it's a miracle I didn't blow my brains out. And this is particularly relevant because it's not just me. At the American College of Surgeons, when I gave my talk, another surgeon gave her talk and talked about a surgeon who went and told the chair that he was severely depressed. He was told to leave, get a psychiatrist, and then 4 days later they found him hanging from a rope in his house. So the peer support program that Joe is talking about and at Mass General is so crucial, and I think it should be extended, in my personal opinion, beyond just second victim challenges. And as was talked about earlier, people sense when there's something off, and I learned later that people knew I wasn't quite right. You know, I was just not the same Mike Maddus, but nobody said a word. You know, nobody said a word, and it's understandable. People don't know how do people deal with people with addictions and that sort of thing. So it was a incredibly hard time. And I also want to talk about shame, and this will get to Carrie's question about going back. I mean, the mixture of things going on in my life as I considered returning to work. I had the physical issues, of course, and the devastation around my family and all the stuff going on, and my sense of moral failure to my profession that was beyond comprehension. But then the shame generated by all of that. And shame is a very unique and powerfully devastating emotion. It's one that says that you are not worthy relative to other human beings. And there's no way out of it except to expose it to the light of day and talk about it. And that shame was so profound for me that it played a huge role in my inability to go back to work. It really did. But more than that, and I want to get into this a little bit because I think it's really important. You know, as surgeons in our training, and you know, we start out and we go to college, and then we get into medical school, and then we go to surgical training, and then we get our career, and that's a whole new thing that we start. And that entire process, we learn how to say yes to everything. We learn to have huge amounts of discipline. We learn how to be strong and pretend we're okay when we're not, which has been talked a lot about today. We think we have to be self-sufficient in everything that we do. And then, of course, we have this idea that we can fix everything. And suddenly, you know, emotional struggles, loneliness, all these things, there's no fix for in the usual sense. And so these habits, although extraordinarily valuable, it's like anything in life. They're good until they're not. And I believe that this is a root part of the cause of the misery that surgeons endure in their lives, because we don't bring in necessarily best practices from the outside world in mental health, self-compassion, meditation, mindfulness, and things. These are really good practices. They're best practices in the world of mental health, and they make a difference. And so, you know, wisdom is the ability to have equanimity between those two, to know when to apply the good habits that we learn as surgeons and when to back off and take time to address our emotional needs, our needs as human beings, and all the rest of it. So I don't know if I answered your question. I went off on some tangents, but.
Talk about when you walked through the hospital the first time.
Oh.
Yeah, I'm going to make you tell that story.
So I went up to the chair's office, and they told me that I had to leave, and like a good soldier, I stood up in my nice sport coat and tie and took the elevator down, and as I was walking out, the CEO of the hospital, of the group practice, who I knew very well, we worked together when I was a resident on the service, on the transplant service, and so we knew each other for years. She looked right at me and then looked away and kept walking, and I walked right near her. So she knew, because I was fairly high profile in the organization, I'm sure that she was talked to about it, what was going on. And you know, that was a devastating moment for me. And of course, you know, you don't know how, that's like almost trauma, you know, that sort of thing at that level. And you don't know how, you know, how that factors into the aftermath and trying to decide whether to go back to work, like, are you valued anymore, all those things. So it was really, really, really difficult. And again, I'm not blaming anybody. It's the way it was at that time, at that moment in time. And I do believe most people have, they try their best in the given set of circumstances. This is new territory for everybody at the University of Minnesota.
Thank you for sharing that. Next, Colin, I'd like to chat with you a little bit. Can you tell us a little bit more about what you've learned, you've been researching this for a very long time, about the relationship between burnout, we've heard a lot about that, we hear about imposter syndrome, depression, and mental health disease, a real easy question for you to tackle in a few minutes. And then also, namely, how does this potentially impact, you know, I see, I'm used to getting uncomfortable today, I can say anything now. You know, our group, you know, the best I could do, you know, I'm saying is, you know, our profession, your profession, our profession is dominated from the top down, research-wise. I won't say men, all men, but predominantly white and privileged people, right? So just like we're talking about diversity and equity and in everything else that we're doing, in residency and leadership positions, how do we make people from underrepresented minorities and populations feel comfortable seeking help from someone that doesn't look like them? Go ahead, you have 5 minutes.
Yeah, so just as easy as all the other questions. So I'm just gonna maybe start off by making a slight correction to the intro bio. I am certainly not the OG in this work. I put that in there because at a meeting I was at a few months ago, somebody said I was one of the OGs who'd been doing this for a long time. And they might have meant old guy, just to be clear. But I thought it was funny, and so I've kind of, and I'll try and answer the questions from that perspective, from that lens. The representation issues are really important ones, so bring me back to that, please, if I get off onto a tangent. But I want to start out with the imposter phenomenon, the self-valuation that Jesse spoke about in the previous session and has been mentioned already. All of these issues are both and issues, in my view, across well-being in medicine. And I make that point at the start because we've evolved, and I guess this is healthy, but we've evolved to a point where different factions within well-being are now trying to compete for the microphone. And we actually need to remember that we have the same goals. So it's burnout for some people, it's moral injury for other people, it's compassion fatigue for some people, it's depression and diagnosable mental illness. They can coexist, they can be separate. They are overlapping Venn diagrams. So that's a background piece. What we increasingly learn over time, however, is that there are aspects that have differential priority for different people. So the imposter phenomenon, or imposter syndrome as people talk about it, I think closely relates to this self-valuation concept, where despite all of our accomplishments, despite what I think any objective observer would identify in our skill sets, our training, our intellects, we don't see that ourselves. And if you don't mind me personalizing, since you've personalized with Mike, that's like being a 31st or 32nd ranked tennis player in the world and still feeling like, yeah, I didn't meet my potential, so I'm an imposter. My self-valuation isn't where it needs to be. And I mention that not to point any fingers at anybody, because we all do this, and it's the double-edged sword of these sort of perfectionist, dutiful kinds of objectives. I can't remember whose slide it was on in the last session, but there's a great paper on the physician personality from Glenn Gabbard dating back to 1985. So this is not a new concept. And it talks about how there's adaptive features to that personality and there are maladaptive features. Imposter phenomenon and low self-evaluation are part of the maladaptive part of it. We don't believe, we don't have the self-compassion, and by the way, we don't extend that to our colleagues often enough to let them hear in what high regard we hold them, to acknowledge what we bring to the table. Because it really is unique and special, but we feel like, yeah, I'm gonna be found out at some point. It's not real. And that very much contributes to this sense of distress that we bring with us every day, because we don't just have stressful jobs with high impact on patients and all of the obligations and responsibility that entails. We're carrying this, yeah, I'm doing all this stuff, but I'm not sure I'm really the best person to be doing this. I'm not sure I'm really qualified. I don't know, somebody's gonna find me out. And we instill that in people from the earliest stages of medical training. When we, the way we question people. Carrie, you mentioned in your address about what's the tone of M&M. I was in med school in the early 90s.
By the way, it's not that way at MGH, I just want to say that.
Well, and so this is, we're talking 30 years ago now, but M&M was absolutely shame, blame, humiliation. You will never make this mistake again because of the experience you've gone through, and everyone who's in the room and sees what happened to you will be too afraid to make that mistake as well. Fear is a great short-term motivator that burns out and leaves damage in its wake. It's not an effective educational or growth strategy. And I think in medical education, we've been very, very slow to pick up on that. So all of these things are interrelated. You can experience burnout and not be diagnosable with major depressive disorder. You can have major depressive disorder and not necessarily have burnout. I think it's really important that rather than getting hung up on, it's not this, it's this, think about the larger holistic sense of well-being. And when you're concerned about individual terms, do your homework, because there are decades of research on these fields. And I think, I can't remember out here, maybe it was you, Mike, made the comment about in surgery, you don't always, and I'll say this for internal medicine as well, in medicine, we don't always look outside our borders to learn from other disciplines who have been thinking about these things along with us for a very long time. Now, back to the representation piece. So you're absolutely right that many traditionally underrepresented groups in medicine have not been represented nearly enough when we're talking about these well-being issues. Some of that is a reflection of the larger issues across society and across the medical profession, and those things obviously need to be worked on. Some of it is because studying smaller groups by representation gets difficult when you're worrying about, from a research standpoint, we've actually at times been blocked from studying potentially identifiable groups, because when you've only got, by demographic subsection, one self-identifying black, non-cis type individual, suddenly everybody knows in the data analysis who that person's gonna be. And we've had IRBs tell us you can't study it because you have to aggregate in your groups. And that's where you end up with these problematic manifestations of, well, we've got white and then we've got the experience of non-white, or we've got male and non-male. I think that's slowly changing. There are some people working, for example, in the LGBTQ group. Amy Vinson has been working in anesthesia on these issues. So we're starting to break through some of that, but it probably is gonna take national collaborations just so we can have safety in numbers to be able to tell the stories of all of these groups that deserve to have their unique experiences brought forward. I'll maybe stop there and you can take it wherever you want.
That was fantastic. Jill? If you don't mind, sure. Are you hot? You got a hot mic
Yes.
there? Okay. Well, now that I know your entire bio, I'm going to ask you, you're not going to be prepared for this question, other than, first of all, thank you for being here. You've been a tremendous support to me, and you were to Tina. And I'm hoping you can tell, again, I'm sort of telling the story from a let's try to improve aspect. you wrote a beautiful piece, which is up in the reflection room, which I recommend everyone stop by in 333. And I do want to personally thank Imani McElroy for the artistic vision and basically everything to do with the room, and also JJ. And it really was a lot of work, and I just wanted to thank her for that and for her vulnerability in the lunch session. Excuse me. If you could comment a little bit on, we talked about this last night for a while about how we think it could have been differently with Tina, like what we could have done differently, what the focus was for her. I think you've been hearing a lot of themes today, but maybe, and then I'm gonna talk to Dr. Bundy next, Chris, sorry, regarding his role in PHS, because I believe Tina was involved with that program in Massachusetts, which I've had a fantastic experience with, but it may have been different 10 years ago, and it may be different from state to state. So if you could reflect a little bit about how meaningful this today is for you, I hope, and reflect a little bit about how the Physicians Health Services and other, how we can approach things differently.
Well, thank you for inviting me and bringing me here. It's nice to be back in this room. I had to Google some of Tina's former colleagues and her friends to know what they look like now. I'm 41. I met some of them when I was 14 and in high school, and some of them when I was 19 and in college. So Tina and I were exactly 4 years apart. So it's really nice to be back in this room and to hear terms and discussions that are happening here. It feels familiar, even though it's been a number of years. So thank you so much for having me, and thank you for your courage, for literally standing up and making a difference this morning. It was one of the most powerful things I've ever witnessed you do, and I've witnessed you do some powerful things. So I think that, we lost my sister 11 years ago this spring, and definitely and 13 years ago was when she first became ill and started battling with her own mental health issues. And what I remember from that time is that the goal was to find medications that would work so that she could get back to work. And I was working at a nonprofit organization and living in southern Maine, and I'm a lesbian, and I'm really crunchy. And what I remember saying was, could she go to like a 3-month yoga retreat? And I didn't think that necessarily a 3-month yoga retreat would solve all of her issues. And I definitely am pro medication and anything that it takes to treat mental illness. But I really just believed that she needed a break and some time to reflect. And all of the resources that were available to me when I struggled with my own mental health issues just weren't available to my sister. Being able to pause, being able to rest, being able to eat, being able to be around people that loved her, being able to find joy in things that weren't surgery, although she loved being a surgeon. And so what I've heard today is that that's changing, and that has been very healing for me. And I can't wait to tell my partner and my family and folks back home that it sounds like things are changing. But things won't change unless people continue to talk about this openly. I work in politics. I try to get women elected, especially women from the new American majority. And if you can't see other people run for office and serve in office, you don't think that you can do that yourself. And so I think that if you all don't talk about your own struggles openly, no one else will know that they can do that and that they can get the help that they truly need. So I want everyone in this room to stay in your field, to continue to be brilliant. We need you. And you need to do that for each other. And you also need to do it for your patients. I ran into my primary care physician at a yoga class. The doctor who was trying to help my wife and I start a family through IVF, called me personally and was crying when he told me about our negative outcome. My acupuncturist, when I had my miscarriage, I said, I need help. And she said, let's get you some help. I've been there, right? And any of these medical providers, and I know acupuncture is not a medical field, but anyway, any of my providers who showed me that they had experienced things that I was experiencing and showed me that compassion and normalcy, it didn't make me want to run out of the room and stop seeing them because they weren't this godlike perfect figure anymore. It made me want to see them more. And so I just encourage that as well. Being human to your patients will hopefully help them disclose more to you.
Thank you, Jill. Chris, first of all, thank you for what you do. When I was first referred, I was not happy to be referred, let's put it that way. I have a feisty side. I'm sure you guys have picked up on that. But I really think, I truly think, having gone through the program, not through it, I'm in it, and having spoken to, I went to a fantastic group in Chicago called the Positive Sobriety Index, I keep saying that because I do health-related quality of life research. That is not what it is, it's an institute. It was really a phenomenal group. I got to learn about different physician health programs throughout the Midwest because I was in Chicago. And I think that the area of physician health services and PHPs, I keep calling it what is the P for? Programs. I think are an area that are underutilized. Not many people know about them, and I think it's something that can really be improved upon, be engaged with, to advocate for ourselves. I'm going to keep talking. I'm going to let you talk now, though. So can you, first of all, I think there's a burning question that people have, people who don't even know that they existed. Let's start there. But what are they? What is the goal? And I know it's different in each state, but as in your role as the federation president, and what do you see as the most important barrier to people seeking your help or beyond licensure and credentialing? I'll just let you talk now.
Thanks. I was so relieved when you picked Jesse to go first, because I was so worried it was going to be me. But now going last, I'm a little self-conscious too of so many great things that I've gotten to hear. Thank you for inviting me to be on the panel. Actually, I want to tell the audience when Carrie reached out to me to ask me to be on the panel and to discuss with me a little bit about sharing her story, because I work with physicians. So it's my full-time job as the executive medical director of the Physicians Health Program. And this question does come up. How do I tell my story? How do I share this with people? So on and so forth. But one of the things that really stood out to me was how happy you were at the point at which we were coming in contact with one another. That really came through to me. And I wanted to make that point as part of all of this. Is like a lot of what we've talked about is super heavy. But there's really a wonderful, miraculous, bright, shiny unicorns and rainbows story, oftentimes at the end. I'm sorry that your sister didn't experience that. In the time that I've been with the Physicians Health Program, actually a little longer, 11 years, we've had 5 participants in our program who have died by suicide. I carry those. That's my work, is carrying those. I've also had 3 letters written to me and to the Physician Health Program in the last month of individuals who, really wanted to express in a very deep and meaningful way how important the Physician Health Program was to them and how it changed their lives. And how it saved their lives. Actually, 1 in 5 program participants of my program say that the program is life-saving for them at program exit. And I can't tell you how many physicians over the years have told me that they had either made an attempt on their life or were about to at the time that they were referred to the Physician Health Program. We are actually in the week of celebrating 50 years since the seminal article, The Sick Physician, came out in JAMA, which really started the whole physician health movement. As Colin mentioned, there's a lot of bright, shiny objects out there right now in the physician health and wellness space, and everybody's excited about this, and there's a tremendous amount of excitement and help available that wasn't there 50 years ago. But this week, it was actually February 5th, of 1973, when this call to action came out from JAMA that started the physician health movement that created physician health programs nationally. It was really a call to action that said, state medical associations should take the lead in being responsible for health and well-being of doctors who get sick like everybody else. No protections that are unique to the field. Being a physician doesn't give you some special powers against getting sick, and that when you get sick, you should have help. You should have treatment, you should have confidentiality, you shouldn't have discipline. And at the time, because, and I would say fear, shame, stigma, and denial as the barriers, as well as cost and some very real financial and practical difficulties are the main barriers. Those barriers exist today, but those were recognized as being significant barriers that would prevent people from getting into treatment, and therefore professional consequences would typically ensue before somebody would get help. And those were professional consequences that people sometimes couldn't walk back from. We exist today to provide that therapeutic, confidential alternative to discipline along a spectrum of illness. Not all illness is impairment. That point has been made, and it needs to be emphasized over and over again. I don't have the resources to serve every ill physician in Washington. I do have the resources to help people who have progressed in their illness, sometimes despite their best efforts, to the point at which it's beginning to affect their practice and affect their ability to safely practice. And I guess my message would be, even if you get to that point, help is available. And I think getting help is really confusing because of all the resources out there. Am I burned out? Am I depressed? Do I go to mental health? Do I go to coaching? Do I do some peer support? Like, what do I do? And I think, physician health programs, I would say, have been doing this the longest. There's never a wrong answer in terms of calling the physician health program. You can call and you can say, I don't want to tell you my name, but I have a friend who's having like this difficult, you can call us anonymously, ask us for advice and support. That's a lot of what we do, is just provide help upstream of impairment and get people connected to the right support and resources. But for those who need advocacy, who need some support in the workplace, who need some support related to licensing, we're definitely a place that can help with that. So 90% of my program participants are actually unknown to their licensing board, really able to take advantage of that therapeutic alternative to discipline, usually have something going on where a workplace or a credentialing entity or some concerned other needs to know that they're okay and safe to practice, and we provide that. And 75% of our program graduates report needing and benefiting from the advocacy that we provide. Stigma is real, and I'd say what we can all be doing is be looking down the mountain. Wow, we've come a long way in 50 years. There's an amazing groundswell of support that has developed, and the pandemic has really been a lightning rod around that and has really helped generate increasing momentum around these issues for us as a country and as a field, and not get too preoccupied with how far we have to go, but just continuing to do the work. And some of that work, if you want to scratch the surface of, none of us wants to believe that we would have biases or have stigma about mental health or mental illness. But if you ask yourself some of the important things, when I have a doctor referred to me who needs to go for 3 months of residential substance use disorder treatment, on the back of who does that occur? And that often happens right on the back of that professional. And why don't we have systems in place if you had a heart attack and you needed to be in rehab for 3 months related to that, or you, for God forbid, had a skiing orthopedic injury that took you out, a choice that you made, right? To go skiing, and God, it's on you that you were skiing too fast and broke your leg, but you know what, we're gonna support you. Your benefits are gonna cover your care. You're gonna be supported while you're out of work. You have short-term and long-term disability. It's not gonna be questioned if you wanna access those resources. But for physicians who have mental health and substance use problems that take them out of the game for a while, there's precious little support from the system that benefits from the work that you do. So I think in terms of systemic solutions, we also need to be looking at those things. And it's not just having the resources available, but as Jesse pointed out, it's can we actually use those resources? Are they actually usable for us?
Joe, did you have a response?
Yeah, I just want to build on what you said, Chris. So, I was talking about peer support. When we do training for peer supporters, what I say is one of your jobs is, so for some people, formal peer support like we provide is going to be enough, but there's going to be plenty of people who need and want more help. And so one of the things we train is for the peer supporter to both destigmatize and facilitate referrals for further support, whether it be PHS, in Massachusetts, PHS, or behavioral health, or legal, whatever it is. And I think, I just want to say this again, that, and I think, is it Amani, I think was speaking earlier, it's so important that we make support easy. And not just easy, but that we don't put the burden of somebody saying, I'm suffering, I can't bear this anymore, and I'm going to find those resources, that we reach out when we either see that people are stressed, or, and this is also a tenet of peer support, is when we know there have been stressful circumstances, whether it be just like sad things that we've seen happen to patients, or it could be errors, it could be patient aggression, it could be named in litigation, it could be being reported to the board, whatever it is, there are things that we know are potentially stressful. Why are we waiting for people to both start to fall apart and then asking them to figure out, how do I even navigate this? And it just struck me when you were saying, like, people that you hadn't even heard of. I mean, this is just mind-boggling that, I've worked with PHS for years through, we teach a course on managing workplace conflict, but the fact that that you didn't know it was, I mean, that's on us, is that we have to make it easier. And so one, I'm not saying peer support is the answer, but it's an example of where you want to put it out on a platter. Hey, I'm calling, I'm reaching out because we know you had there was whatever it was, a death in the OR, or it doesn't even have to be that dramatic. I'm reaching out, we have a peer support program. I reach out because I and every colleague I know has been there. And some of us find it really helpful to talk to a colleague about that. Is that something you'd like to do? And if they say no, you say, no problem. I do have a list of further resources. If for whatever reason you or your colleagues, think you might want something, and it would include, the suicide prevention, it would include, all sorts of resources, PHS, and if we do the peer support intervention, to say that, hey, look, sometimes the healing happens, but sometimes it gets under our skin. And if it does, I want you to have low threshold for either reaching out to me and I'll get someone to help you, or you on your own, hear these resources. So I just think this idea of making it easy, and not just easy, but it's right in front of you, and it's seen as like, of course we reached out to check on you. Of course, that's what we do. That's who we are. Can you believe that we used to just let people deal with these traumas on their own? Okay, we're still doing that, but that's what it should be. Like in a couple years, I think people are going to be like, how come I didn't get a peer support call, or how come, I really think so. We will, I'm an organizational culture change warrior, so I just feel like we're going to do it.
And then if I could just add, at Mass General, they make it an opt-out process. You have to opt out of it when they reach out for peer support.
No, that's, that is exactly right. So the peer support programs that I've helped start, including MGH's, you get offered. If you don't want it, you don't. I mean, nobody should be made to talk about any kind of trauma that can traumatize people, but it should be made easy. Would you, something you'd like? No, that's cool, no problem. I'm here if you need me, just give a holler. And instead of having just a reach in where people have to be like, oh, what was that? And isn't there something for, impairment or so, it should be like, no, we make this easy for you.
I want to make a couple of comments, and I'm glad, Chris, that you brought this up. I talked about a lot of tough times I had this past year. It was when I was having coffee with Michael this morning. He actually said, you look like you have light in your eyes, because he's seen me before. And, people in recovery can sometimes be annoying because they're like so happy all the time. And you guys would meet them like,
You earned it.
Where I earned it, but now I know why. They weren't. It wasn't BS. They actually feel that way. I used to be like, oh, you're lying to yourself. You don't. But that's not true, because you've spent so much time focusing on whatever feeling it is. Even if you're having a bad one, you feel empowered to be able to handle it. And for all the reasons I said earlier, I'm in the best place that I can remember in as long as I can remember. And that's genuine, and I think people pick up on that. So I want to say that, and I didn't, even a month ago, you would have asked me, and I didn't think I would feel this way. So you do actually have to trust the system and the people who went before you to know that you can get here. The other thing I want to say is, Joe, you said this, which I think is very important, is that the people who are listening today and who will listen to this later, it is not your responsibility to do what I did today. I chose to do that because I was ready to do that. There was another thing that earlier that I actually did not do because I wasn't ready to do it, to speak in front of people. And I just feel like that's very important, that you don't feel like you need to share. You share when you're ready to share or not at all. You do whatever you need to do to feel empowered, to get better, to find a small group that you can connect with. This isn't everyone's responsibility to do what I did today. So on your, I just want to clarify that, that, like you said, like it's your time to share if you need to or when you do. So just wanted to clarify that. The last little point, I'm just thinking of these things that, Michael, you said, you know, you tried to quit, right? I did quit, but that didn't fix the problem. And I just want to really reiterate that if someone just says, oh, just stop drinking, oh, stop doing, you know, doing those, whatever it is, that is not enough. And that, as I said before, it's the smoke, not the fire. It doesn't mean it's not important, but you have to still work on the things that underlie the reason why it became a problem. On that note, I'm wondering how, two things, because we only have 10 minutes, believe it or not. Two things I want you to address is how can people in the audience get involved in their either within themselves, in the system, and I'd like each of you to make a brief comment on that, quite honestly. And then the second thing is, what about trainees? Trainees and students, because they don't have the resources and they don't have the time to go to an appointment at 4 p.m. on every Tuesday. It's just not going to happen. Sunil, will you start? Maybe we'll just work our way.
I'm glad you mentioned trainees. It's a particular passion of mine, not only out of my job, but because I have such palpable memories of suffering as a trainee. And I think the one thing I never felt comfortable doing was talking about it. And what you've done and what I hope we're doing is destigmatizing talking about it. And the reality is, as trainees, we are going from morbidity to mortality to mortality to morbidity, one after the other. And although it's concentrated on one day of the week where we talk about it, the reality is our day in, day out lives as we face our suffering patients, and it's hard not to take that suffering with us. So talk to a friend. Find a friend and talk to a friend. I hope by now those of us in the crowd have a connection with people, and that genuine psychological safety that can be found in that is great. If you don't, speak to one of us, and we'll help you as best as we can. The reality is it's a voyage. It doesn't get a lot easier, but knowing that you have others that have got your back, I think is a huge support. And it's a universal experience. That's the other thing. The isolation, I think, is really powerful as a retardant from actually connecting with others. That barrier is very hard to scale. But when we are comfortable talking about how, whether that's a liver graft failure in my world as a transplant surgeon or a liver remnant failure as a hepatobiliary surgeon that essentially gets transferred to my judgment and who I am as a surgeon, that is hard to shake off when you face the next patient in clinic. You have to talk about what they're facing in the days ahead. So talking about that, destigmatizing it, and being there for one another.
Well, I guess I have three things. One is, you know, when I went to Hazelden, just as a side funny story, I was voted least likely to succeed, which is not good in a rehab center, okay? That's not good, in case you're wondering. But I was voted at the end most improved, which I don't know what that means at that baseline, but nevertheless, I took it and ran with it. But my point here is that 3 months of not being at work and in my life was incredibly valuable, as difficult as it was. I'd never had a moment down. You know, I'd just been hustling and pounding my entire life. And so it was the first time that I'd ever had a period to reflect about my life, about what I was doing. How did this happen to me? What was I doing wrong? Blah, 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 all that stuff. So time off and the ability, as Jesse talked about, is so crucial, you know, to really get a grip on where you're headed in life. And that gets me back to the second recommendation. And as I alluded to before, we run through our careers and our lives, and we're on this incredible fast track. And we don't take the time to really get to know ourselves and learn about ourselves. And we think we might be happy in our situation, doing everything that we're doing. I can just tell you that in my career, there was a lot of stuff I did that I couldn't stand. And I did it because of the yes habit. I didn't learn how to put up boundaries about what I wanted to do. I felt like everything was crucial to my academic career. I didn't learn how to say no and have clear parameters around my time and where my energy went. And now all that fed into part of the misery. It wasn't the only thing, but it was certainly part of the misery. And then the third thing is, as Sunil alluded to, finding connection. And remarkably, after I got out of treatment, and I retired then, but surgeons in the community started calling me. And I thought they wanted to get together for breakfast. And I thought, well, they're just feeling sorry for me. You know, they just want to come out and say, hey, you doing all right? Turns out they wanted to talk about all their troubles. And now, because I wasn't at the U, and I was a safe person to talk to, they wanted to do it. And it ended up being 6 different surgeons I was meeting with all the time for breakfast, right? And I ended up coaching them. Well, I brought them together as a group. And this came from a book called True North Groups, and there's a famous leadership book, True North, by Bill Lockandis. He was the previous CEO of Medtronic. Anyway, he advocated creating groups outside of work and outside of family, a place where we could be vulnerable and strict confidence, and you can form close relationships and talk about all the stuff that you can't talk about at work or at home necessarily. You may not get the right support. So I created a group with these surgeons. It's been going for 5 years. These are very busy people. They come twice a month to breakfast, you know, and it's been incredible what it's done for them and for me. I mean, just the relationships that have been formed. They have a place to talk about their struggles and failures at home, with the kids, at work, losses, all that stuff. And as another way of doing that, I've created a virtual book club where the idea is you bring them in as be reading about books and learning about these best practices that I harp on. But what it ends up being really is a place for us to be in confidence and talk to each other and learn and bring up stories that are based on the things we're reading in the books. Again, critically powerful. The 5 people that are in this book club, they don't want anybody else in it, and they're showing up despite their very busy lives on a Saturday or Sunday morning to the book club. And as connection has been brought up here again and again and again, and I just can't emphasize what a wonderfully salutary element that is in our lives, and how I didn't recognize how lonely I was when, you know, I started getting addicted to stuff. I thought I was just being weak. Everything felt like I was just being weak, and I didn't know what to do except pull out my old surgical habits, and they, of course, failed me.
Thank you, Michael.
Yeah, thank you. Yeah, so I think of it 3 Venn diagram circles. One is what you can do for yourself, which is self-compassion. And it's really hard because it's not our training. We are just merciless with ourselves. It's really impressive. So I think just working on that and knowing that you're not alone in lacking self-compassion. This is we are all a product of this culture that has been embedded in, and we've, you know, I have also drank the Kool-Aid as I drank the Kool-Aid as well, but we have to sort of find another way. So I think that's one. And then the second is relational. I echo what you said, that there's just even coming to a meeting like this, right? This is community. This is community. Find community. Yes, it takes, you know, we all just want to get to work and go home because we work-life balance, but doing things outside of those 2 realms, it's really important, including this work here that you're doing. And then the last is, and depend on your stage, you may or may not have the bandwidth or interest in doing this, but as I say, I'm a cultural change warrior, and my motto is, when I see a really bad culture, which I think we have in some ways in medicine, is, excuse my language, but this is bullshit. Let's blow it up and build something beautiful. And to the extent that works for you to get involved in those efforts, do it. I find it unbelievably replenishing. And I just want to end with a tweet that I thought was amazing. It's from 2021, Zandashi Lorelia Brown. I dream of never being called resilient again in my life. I'm exhausted by strength. I want support. I want softness. I want ease. I want to be amongst kin, not patted on the back for how well I take a hit or for how many. Instead of hearing, you are one of the most resilient people I know, I want to hear, you are so loved, you are so cared for, you are genuinely covered.
That's beautiful. And I want to add the self-compassion thing that's been brought up multiple times here. And when I encountered this idea of self-compassion, I happened to read it in a paper, and I thought, what the hell's that? All right? Literally. And so I looked it up. I looked up Christopher Germer and Kristen Neff, and I went to a self-compassion retreat. Now, here's a thoracic surgeon, male, okay, tattoos, ex-juvenile delinquent, going to a retreat in the desert with 60 women and a few guys, all right? And I'm in a room and they're telling me to put my hand on my heart and get in touch with all this stuff. I was such a fish out of water, but it was one of the most transformational things that I've ever done. It awakened me to the other side of living and a way of being that was so profound. And it was 5 days, you know? You could do that. These are the kinds of things you can do to get out of your world and see a different way of looking at how we can live.
Yeah, no, I only have a few more minutes, I'm sorry.
I might have messed with this. Hello? Hello? Okay. So now we have like no time and I'm finishing after like a really good tweet and stuff. But, you know, when I think about this stuff, I think what's important is that like we think that there's like a one-size-fits-all solution to these things, and that's not the way to think about it, right? So people come and they'll say like, I tried mindfulness, I hated it, now I'm bad at coping. There's no such thing as being bad at coping or failing at coping. You have to figure out what works for you. And we approach it really poorly when we just think that like this one solution is the answer or this is the one solution that we're making available to people. So know that like you should view coping more like hobbies and things that you try out and you see if they work and see how that fits for you. Try not to immediately judge the cheesiness of some of it. So there's a lot of mental health related things that sound silly, like make you just want to punch someone. They sound super woo-woo. I hate most of them. My therapist is always shoving it down my neck. But you have to go like, would that work if I didn't judge this immediately? Is there a place for that in what I'm doing? And you can try it, and if it still feels super woo-woo, it's okay. You don't have to do it. But know that it's important to try that stuff and not just immediately dismiss that. And the third thing for me is sleep is really important. So I hate when people, like doctor people tell you to sleep. It's like the worst thing anybody can possibly do. Like patients hate it, everybody hates it. But sleep has a really significant impact on all things mental health, and I didn't even realize it myself until I actually took a second to realize like I was up scrolling social media during the pandemic instead of sleeping, and then I would like want to sleep after work and felt miserable. So realizing that sometimes just prioritizing that stuff where you can is okay, that as a trainee, if you need to sleep for your weekend off, that doesn't make you a bad person, it doesn't make you a bad friend or partner. Sometimes you just need sleep, and that's okay. And give yourself permission to heal and recover however you need to.
We have a few more minutes. I'm not getting the cane. Go ahead, Jill, if you want to say anything. No, you're good? Okay, Chris? Oh, not Chris, sorry, Colin.
Two comments. The first is in terms of what can we do, what can all of you do? The path to well-being runs through what I call the MVPs of well-being, meaning, values, and purpose. You have to figure out what the right connection to meaning, values, and purpose is for you. But this is true for trainees. This is true for practicing physicians. It's true for program directors. It's true for leaders in medicine. If you think about connecting yourself, those around you, your charges, with meaning, values, and purpose, you will be promoting their well-being. And then the second thing that I'll say is I think hopefully maybe a message of hope, as this has been a very long path to get to where we are on this stage right now. We can't address what we refuse to acknowledge. This meeting is about opening the doors and shining a light on something that we have to acknowledge, not just in surgery, but across medicine as a whole. And there are a lot of folks who have been working on this for several decades, on this panel and elsewhere, who have been advocating and pushing. But it takes, as was said earlier in the session, marrying data and advocacy with stories, the emotional tug, and seeing people be vulnerable, like Carrie was earlier today, like the Feist family has on behalf of their sister, Lorna Breen, like you have, Jill. That's how change happens. And to paraphrase Hemingway, change happens slowly, then all at once. And I firmly believe that we are heading very, very close. We are on the cusp of that inflection point to doing what Joe spoke to. blowing up these old dysfunctional status quo ways of doing things and building a new future that's better not just for us, but ultimately for our patients and our healthcare system as a whole. That's why we're all here, and this is an example of the movement that's been growing.
Thank you, Colin. Chris?
I guess I would just say focus on yourself first. We've kind of, if you think about the Stanford model of professional fulfillment and wellness, there's personal resilience, which if you don't like resilience, think of another term, but sort of your personal well-being. Think about where you can make some inroads on that, because we're all just, people who have had, are having, or will have problems. Human suffering is ubiquitous. If you have a pulse, you're going to suffer. So you need to work on stuff, regardless. So that then, I think, gives you the connection to the larger issues of cultures of wellness, where you've experienced self-compassion, you've experienced something that you've done that's helped you then connect to the larger piece where you say, I want this for other people, and I think I have some ideas about how to do that. And then be a part of that change you want to see in the cultures in which you work, and settle for nothing less. Settle for nothing less than cultures of wellness where people treat each other with kindness, civility, respect, and compassion, especially in surgery. I mean, I hate to say it, but I see surgeons every day, and I know what kind of cultures that you work in, and this needs some work. And you can do this. That's something that you have direct control over. And then finally, the AMA calls it stop doing stupid stuff. And if you've got yourself, your own resilience or your own personal wellness dialed in, and you're working on a culture of wellness, and you can also sort of stop doing stupid stuff. And that takes the capacity to dare to dream for nothing short of revolution. I mean, the concept of, we can't do opt-out psychotherapy for every medical student. Why not? Why can't we do that? Why can't we ask that question? Why can't we make that available? Talking about students, talking about trainees. We really have to be prepared to question fundamental assumptions about how we do things in order to fix the system.
Thank you. Yeah, please, Jill.
I did think about the thing that I was an expert on, and that is that my sister went to bed with a Fisher-Price medical kit when she was a child, and through her entire life could not imagine not being a doctor, and made the decision to be a doctor when she was 17 and got on this treadmill. And I think about all of the stops and starts I've been able to have in my own life to land where I am now. And I just want to say that the people in your life love you so much, even if you're not a doctor or a surgeon. They do. And they love lots of things about you that are not that. And they're proud of you, and they are so in awe of your success, but they also love that you make really delicious cookies and write meaningful thank you notes and spend time with their dog. So just remember that it's okay to pause, it's okay to take stock, and the world needs you for lots of reasons.
I don't think we can follow that up with anything else. Thank you. She made really good cookies. Thank you to all of my panelists. Thank you so much for being here. And I'm sure, please, all of these websites and QR codes, they can be found on the internet. You guys know how to find them. But thank you so much for all being here, for your commitment.